Come learn about juvenile scoliosis. Scoliosis can be diagnosed at any age, and it can affect all ages. Congenital scoliosis is a type of scoliosis that the babies are born with, and it's very common. It can be associated with something that we call infantile scoliosis. Infantile scoliosis is when patients develop scoliosis or diagnosed with scoliosis between 0 years of age to roughly about 3. Once patients break 3 years of age, but less than 10, this is when we diagnose patients with juvenile scoliosis. And adolescent scoliosis is when the diagnosis is made between 10 and 18. And adult scoliosis is when patients are made when they become skeletally mature. So these types of scoliosis help classify the patient based upon age. Now, typically, the younger scoliosis is developed or diagnosed, unfortunately, the more likely it is to progress during the adolescent stage or during their growth phases. Scoliosis is typically diagnosed by looking or finding an unnatural sideways curvature of the spine. And this development of an unnatural sideways curvature also has a rotational component or a twist. This is what makes scoliosis. So a scoliosis needs to be a minimum size of at least 10 degrees with this rotation that typically occurs into the concavity. Normally this is taken on an X-ray, and this cob angle has to be measured at this size or greater to be considered it can be considered a scoliosis. This cob angle has to be measured on an X-ray of at least 10 degrees or greater for it to be considered a scoliosis. What is juvenile scoliosis? Now, juvenile scoliosis is based upon the age of diagnosis. So when a patient is diagnosed between 3 and 10 years of age, they are diagnosed with juvenile scoliosis. The most common type of juvenile scoliosis is idiopathic, but all congenital cases that were initially diagnosed as an infant scoliosis may not get diagnosed until juvenile, and that'll be called a juvenile congenital scoliosis. But idiopathic is by far the greatest or the most common type. Now, idiopathic scoliosis is when we say there's not an associated single cause that is related to the scoliosis presenting itself. We believe scoliosis to be considered a multifactorial condition, meaning there's many factors that can vary from patient to patient to be causing the curve to develop. In fact, a patient could have more than one factor. So once we exclude all other reasons, we call this idiopathic scoliosis. Scoliosis progresses because of growth, and the progression isn't linear. It means that curves progress when patients are going through rapid growth, and they're not progressing when patients are not growing. But unfortunately, since juvenile cases have a longer span to grow, they have a higher risk of progression, because the bigger the curve is when they get into the adolescent growth phase, meaning the rapid phase, the more likely curves will worsen in that stage. Now, juvenile cases, unfortunately, because they have this long period of growth, it can be either a sign that we have a lot of time to try to improve the curve. But if the curve's already significant and there's already a severe curve in juvenile cases, which I see, unfortunately, often, that is the severe stage with this amount of time of growth and development that can occur, we can have a very severe curve when they start going through adolescent stage. So in juvenile cases, we really try to manage the reduction. So reducing curves in juvenile stages are our utmost priority before they get to the adolescent stage. Now, there are some other causes outside of just idiopathic. I did mention congenital. This is when there's an asymmetrical or abnormal bone that actually happens at birth. This abnormal bone is called a hemivertebra. This hemivertebra is an abnormal shaped vertebra that happens at birth. And then, obviously, if you have it at birth, you're going to have it at juvenile. So a juvenile congenital case is possible. The last type is something we call a neuromuscular case. Neuromuscular cases is when a patient can sometimes present with something called an atypical curvature. An atypical curvature is when the curve bends opposite of what we consider typical. Typical are normally left lumbar, right thoracic curvatures. If we see anything other than that, that could be an atypical curvature. When we see an atypical curvature, they more likely have an underlying problem, either some kind of neurological pathology or some connective tissue disorder that can be associated with the causation of the scoliosis. Things like connective disorders like cerebral palsy, Marfan syndrome, Ehlers-Danlos syndrome, neurofibromatosis, or it could be a neurological problem, something like a syrinx, a tethered cord, that can be associated with this atypical presentation. Now, when a curve bends in this opposite way, we consider this a red flag, and we definitely consider it a red flag when it's happening in a juvenile stage. So not only can it be some kind of congenital malformation with a hemivertebra, but there could be some neuromuscular syndrome, or there could also be some tumors or something associated in the spinal cord itself. Now, what are some signs that a juvenile scoliosis may have an underlying pathology? The first thing is pain. Like, we don't typically see pain associated in juvenile cases. If we see pain in a juvenile case, especially severe pain or nighttime pain that doesn't resolve with rest, or it's not beyond just an ache, we consider that to be a red flag if a patient has a scoliosis as well. A opposite bending curve, meaning a left thoracic curve or a right lumbar, may be associated with an underlying pathology. Any abnormal neurological reflexes or any type of abnormal neurological responses, unequal eye reflexes, abnormal abdominal reflexes, some type of neurological disturbance can be a sign of an underlying pathology. Boys with scoliosis, much less common. So if we see an atypical scoliosis and we also see a boy and we see a neurological finding, boys it's a 1-to-4 ratio. For every one boy, we see 4 girls. So anytime we see a boy with scoliosis, we may consider there being an underlying pathology. We're going to look for it. Any kind of abnormal skin lesions like marking, hair, like any type of abnormal skin pathology that we see is a sign of there being a neurological condition. And the last thing is rapid progression in the juvenile state. Normally in juvenile states, we don't see significant rapid progression. We'll see steady progression. So if we see rapid progression, that could be something, again, neurologically that's occurring, neuromuscular that's occurring. Now, how do we treat juvenile scoliosis? Now, there is no treatment guarantees, but like I mentioned, that early treatment typically resolves or means good results. And in juvenile cases, we're definitely catching it early. Now, if we intervene, and our goal here in the juvenile case isn't just to slow it down, we really want to reduce it. At this young age, the spine is very flexible, making it more responsive to treatment. So if we're using the right types of treatments, we can work towards reducing curves. Some of my best reductions occur in juvenile cases. Some cases, 34 degrees, we can use 50, 60, sometimes even 70%, get very significant reductions using our specific type of chiropractic approach to help reduce and manage a scoliosis. Now, once we reduce this curve, we have to use therapy, rehabilitation, and even sometimes corrective bracing to help stabilize it. The exercises and therapy help increase core strength and help deal with the muscles that are in this growing and developing body to help optimally support the scoliosis. And then we use corrective bracing to help remold or remodel and help stabilize the scoliosis during this progressive development. The idea would be, in a base case scenario, we find a scoliosis in the juvenile stage. We use as much treatment as we need to reduce the curve as aggressively as possible, get it as small as we can. Then we go into a holding pattern and we use minimal care just to try to hold it where it is until we hit adolescence. At adolescence, if the curve doesn't worsen, we made it. If the curve starts to worsen during adolescence, we reapply treatment and reduce it again. So sometimes in a juvenile case, if we catch it early enough, we may have 2 phases of care. We may have one corrective phase, reducing and managing the scoliosis, and then we're going to monitor. Now, a lot of adolescent cases, in fact, the majority of them, is that we can reduce them to significant levels, and we can hold them during their juvenile years. When they hit the adolescent stage, they don't progress. So we completely alter the progressive nature of that scoliosis. So since we know that scoliosis is progressive, our goal in juvenile years is not just to slow down progression. We really want to reduce it, because reducing the scoliosis in the juvenile case will provide the very best outcome. And since these children are so young and they're so adaptable to the treatment, we can make very significant changes if treatment is done. Now, unfortunately, many juvenile cases are not treated. They say, they're too young. They say, let's just wait to adolescence and see what happens. And they're very often pushed aside. And they said, let's just reevaluate them every year to every couple of years. When unfortunately, a lot of worsening can occur in that stage. And now you go into adolescence with a more significant curve, which higher risk of progression, which can lead to a totally different outcome. So the right treatment at the right time for juvenile cases can make a big difference on the future of this person's spine, not only right at this moment where they're growing, but really over their entire life. Thanks for watching. I hope you found this information helpful. If you'd like to hear about other topics and information on scoliosis, type in the comments below and let us know. And finally, subscribe and hit the bell icon to be notified of when we publish content. Thanks.